Good morning, everyone. It is my pleasure to introduce to you Dr. Bruce Perry, MD, PhD. He's a principal investigator of the Neurosequential Network and a professor in the departments of psychiatry and behavioral sciences at the Feinberg School of Medicine at Northwestern University, as well as the School of Allied Health and Human Services at La Trobe University in Australia. Over the last 30 years, Dr. Perry has been an active teacher, clinician, and researcher in children's mental health and the neurosciences, holding a variety of academic positions. His work on the impact of abuse, neglect, and trauma on the developing brain has impacted clinical practice, programs, and policy across the world. Dr. Perry is the author, with Maya Salovitz, of The Boy Who Was Raised as a Dog, a best-selling book based on his work with maltreated children, and Born for Love, Why Empathy is Essential and Endangered. Dr. Perry's most recent book, What Happened to You? Conversations on Trauma, Resilience, and Healing, co-authored with Oprah Winfrey, was released in 2021. More than this, Dr. Perry is an incredibly thoughtful educator and tireless champion of mental health services for children and families. He is a true inspiration to all of us, not only for the work he does, but for who he is as a person. Thank you.
Thank you very much, Dr. Richards, Misty, if I may. I am honored to have this opportunity to share a little bit of our work with you. I have no real disclosures. I know I'm supposed to say that. Aside from the fact that I'm part of a working group that developed the model I'm about to share with you. And I really appreciate the opportunity to talk to colleagues and peers who I think have been struggling with some of the same questions that our working group has been over the last 30 years. So let me go ahead and start using slides, because the last thing you want to do is spend all day looking at my old, tired face. The first thing I'm going to show is this initial slide has a number of URLs and places that you can go to get more information about the work that we're doing. I'm going to show you a bunch of slides. I'm going to refer to some of our studies. Obviously, in a 45-minute presentation, you can't take a deep dive in a lot of those concepts. And so any of you who are more interested in learning more, you can go to pretty much any of these sites and learn a little bit more about our work. There is a group of handouts. There's a URL that has a number of PDFs that have like our greatest hits slides and some of our other recent writings. This URL is going to be added to the chats. So those of you who want to visit that during the presentation for something to do while you're listening to me talk, that will be something that you will have soon. Part of what I'm going to present is it's a little bit tangential to the traditional psychiatric mainstream model of how to understand and solve problems. And I just want to tell you the journey that I took to get to where we are now. And it's probably the best way to introduce the model overall. And I think if you understand a little bit about what I was struggling with and the choices we made as a working group, you'll have a better understanding of why we're doing what we do currently. So I'm fundamentally at heart, I'm a developmentalist. I mean, I have a PhD in neurobiology, and my research in getting my dissertation was studying the development of the stress response systems in mammals. And I looked at norepinephrine and dopamine and serotonin and opiate systems and looked at how certain manipulations at different times during development would influence migration, receptor density, functional output, and so forth. And we looked at this at the level of genetics. We looked at it at the level of microcellular second and third messenger transmission and protein level with receptors. We looked at this at a lot of different levels of granulated reductionism, basically. And those of you who've done much neuroscience, you know that it's a very complex complex world and a very rapidly emerging world. There's more information every day. And yet we have much, much, much more to continue to learn about how the brain works. So I was coming into clinical training in psychiatry with a background in developmental neuroscience. And I had the bias, and it is a bias, of looking at our clinical problems through this neuroscience lens. And one of the things that I struggled with was there was a big disconnect between what I knew about how the brain developed and changed and what I knew about the complexity of the brain and the way in which I was being taught to understand and intervene with individuals. Simple example. I knew that neural networks are plastic and that there are a variety of processes from the molecular level all the way up to sort of the macro level in these physiological systems in our brain, that these systems are changed and that what changes these systems are tiny little repetitive doses of activation. And yet I was being asked to do clinical work. And what was I doing? I mean, what was my theory of change when somebody would come into my office once a week and sit in front of me and color or talk or play? And I kept thinking, what am I doing here? How is my interaction with this child in this moment helping me influence and change their brain in ways that will make them more capable of age-appropriate socialization or age-appropriate problem solving, or improve their fine motor control, or influence sensory perceptive distortions? How was it that I was doing that? And I just kept struggling with that, and ultimately realized that I needed to approach these problems in a different way. Now, I'm sort of summarizing a very long process. I mean, in the beginning of my training, I was a very good boy. I did all the right stuff. I listened to what everybody said. And I kept thinking, well, somebody must understand that, these kids that have, chaos, threat, come from environments of poverty, they've been marginalized, they've been minimized, they've been humiliated, they've been shamed. And now they have problems in school and difficulties with peers. Somebody must have written about the biology of this. Somebody must have written about the complexity of these problems. And I kept thinking that there were people out there that knew more about it than I did. And so when I was told to take these kids and say, well, you have ADHD, or you have conduct disorder, or you have oppositional defiant disorder, I kept thinking, well, they must know what they're doing. They're experts. That must be it. It must be right to give them 3 different labels and to approach this with a variety of psychopharm interventions and or other things that were only episodically delivered in a dosing and spacing schedule that I knew was very different from what changes the biology of the brain. So at some point I realized that the theory of change, I thought what I was doing was influencing and changing systems in the brain. I mean, the brain is the organ involved in thinking, feeling, moving, connecting. And these were the places where these kids were struggling, and where they're often adults I was working with were struggling. So I started to think about, all right, if this is right, I mean, if my theory of change is correct, that the brain, our work with these kids, or something influencing the biology and the organization and the functioning of these systems in the brains of these kids is the mutative agent, is what's going to change them, I need to come up with a better way to categorize, to organize, and to select and sequence my therapeutic, educational, and enrichment work, because what I was doing wasn't working. So we developed over time a model. Now, here's the dilemma if you're going to use a brain, a neuroscience lens in doing this kind of work. The major problem is that the human brain is infinitely complex. I mean, it's complex beyond our comprehension. And so just if you do this simple reductionist examination of the component parts, or just a few of the component parts and some of the dynamic processes in the brain, you see that you've got, like, you know, orders of magnitude of complexity that are just almost incomprehensible. And so the bottom line is, even as a neuroscientist, I had to use models to summarize, distill, and capture principles and concepts that were crudely reflecting what I was seeing, and they may have had elements of distortion and inaccuracy, but we were all forced to use models. And so here's what I'm about to say. Here's what I am saying. Everything I'm going to present to you from this point forward is wrong. So I don't want you to swallow what I have to say as being the truth. Now, there are things that I will tell you that I believe are true. I think there are some accurate representations of key concepts and principles about the brain, how it develops, how it changes, that can influence your clinical work. But make no mistake about it, I understand that what I'm going to present to you is a simplified model that is trying to capture incredible complexity. So let me just go back and look at this, right? Here's the brain, right? People go, oh, that's kind of a nice looking picture. Look at the brain. This is a model. This is an artist's rendering of the brain. The brain's not transparent. There are no colored parts to kind of show you where the visual tracks are. This is a model. Now, the question is this model helpful? And I would say, yes, it is helpful. It's helping us understand that, you know, a little bit about some of the connections related to visual perception. So sometimes a model can be pretty complex, and it can contain and capture a lot of the nuances of complex systems. And this is part of the dilemma that we went through. How much complexity do we want to build into a clinical model that is going to do work with individuals who have been impacted by a whole host of different developmental experiences? And is this model going to be something that will be helpful to clinicians? Will clinicians use it enough to get a large enough N number to actually answer some of the key questions? And so part of what we realized was we live in an evidence-impoverished field. You know, we talk about evidence-based, evidence-generated. The reality is we don't have enough evidence in the area of traumatology. We don't have enough evidence in developmental psychology. And in all of our super and subdisciplines, we don't have enough evidence to really do some of the things that we need to do. So our intention with the development of this approach was to create a way to organize existing clinical material in a way that told us something about the developmental history of the individual. How did they get to this point? And then told us something about how they were currently functioning. We wanted to see current functioning, and we wanted to see the trajectory to the present. And then we wanted to take that information and organize it in a way that would help us select and sequence appropriate therapeutic approaches. Because we knew that there's no one size fits all approach that was going to address all the complex issues that were going on in the central nervous system. The other thing we wanted to do was make sure that there was an evidence generating process. So I'll talk about how we got to that in a minute. But part of what we were struggling with was the current way that we cluster and study and do clinical work in our field. And one of the things that we knew was that we're dealing with, we were, as a working group, doing a lot of work with trauma. And we knew that kids that had significant developmental trauma of all different kinds were basically meeting diagnostic criteria of multiple DSM labels. And that developmental trauma could mimic a whole range of traditional DSM categories. And this led to tremendous confusion and complexity. We also knew and we're very well aware of these two concepts that are incredibly important in our field, but are rarely intentionally taught to our trainees. One is, equifinality, which is basically that you can have, let's pick on ADHD. You can meet diagnostic criteria for ADHD and have problems with attention and impulsivity and socialization through multiple neurophysiological pathways, which means that if you want to study those individuals and come up with mechanism-specific interventions, you have to parse out the route to that label and not make your decisions about research, clinical service delivery based on the diagnosis of ADHD. You need to basically parse it out. The other thing that's very important in development is multifinality. You can have a specific insult of one neural network, and it can have multiple phenotypic expressions across multiple individuals. And again, these two things complicate a descriptive diagnostic approach. And that is exactly what the DSM has been. Now, if you just sort of look at this in a step back, and this is kind of what I was struggling with 25 years ago. And I was like, listen, I know the brain's really complicated. It's got like billions of these moving parts. It mediates thousands of functions. Yet when I started training, 90% of the kids that I was working with were basically given one or more of about 8 labels. And so in order to study the neuroscience of this is just a big mess. It's just a big heterogeneous mess. In contrast to the heart, I just come off, when I went into psychiatry, I just come off doing cardiac ICU for 3 months. And, everybody who was in there had the symptom basically of chest pain, shortness of breath, difficulty of circulation. So the symptom presentations that these individuals had were very much the same, but they weren't labeled and treated based upon their symptoms. They were labeled and treated based upon the physiological insult or the physiological problem that led to cardiac compromise. And so even in a simple organ like this that has very simple functions, pump blood, that organ had dozens of distinct cardiac diseases, which had distinct mechanism-related interventions. And so how is psychiatry, how is mental health going to get from this to this, where we're actually putting together and understanding a labeling system that is not driven by the medical economic model, but is driven by the physiological issues that are underlying the symptom presentation. Now, there are other factors that are involved in that, which we can get to in the Q&A. But in the beginning, I was approaching this as a reductionist because I was trained as a neuroscientist. The additional complexities of community culture, historical experience, and transgenerational passage of experience, including trauma, that's obviously another confound. But even at the reductionist level, our labeling model was inadequate, and it still is, and then we still teach it. I think that the RDoC efforts are a direction attempting to back away from an overly simplistic diagnostic model. And in many ways, part of what we've been doing with this neurosequential model is parallel to what's been happening in the RDoC process. And for those of you who don't know, this is this really a long-term process that is in basically trying to come up with a better way to categorize and organize the functional aspects of an individual so that you can study them not as a big heterogeneous clump, but as more homogeneous populations. And I believe that this kind of effort will lead to further advancement in our field, but that's a whole different thing. So there was the dilemma. Here's the complexity of the brain. We could do neuroimaging, and we did all of that. We did some neuroimaging. Neuroimaging is really kind of sexy, and you move it around, three-dimensional stuff, and that's kind of cool. You can see different parts of the brain look like they're using a lot of, overactive. Other parts are underactive. This is a 5-year-old child who had significant abuse and neglect, lots of early life neglect, and you can see that. And you don't know this probably, but anything that is bright red is at least 2 standard deviations different from neurotypical. Anything that is dark blue is 2 standard deviations less active than a neurotypical population. So you've got neuroimaging. It's kind of cool. Is that the way to learn about? Should we do neuroimaging on everybody and kind of look at the specific organization of their brain? And the reality is this is impractical. Neuroimaging can be kind of cool, but neuroimaging is also incredibly expensive. It's intrusive, and it's not practical. We can't get enough N number to adequately ask and answer some of the questions we need to do in the field. And some of you may be aware of this, but I had come from a studying the impact of intrauterine insults on development. And so I knew from the statistical analysis of that field that in order to see whether or not an agent was a teratogen or caused a problem, for example, you needed thousands upon thousands of cases to get adequate samples to tease out the answer. And even though it was not being done at the time in mental health, I knew that if we wanted to actually get good answers to these complex questions about human behavior, we needed subject numbers that were way beyond the N of 200, the N of 400, the N of 800. We needed N's in the thousands to ask and answer deeper questions. So that was the dilemma. How do we do this? Now, change paragraphs. These are the dilemmas that we're still facing. And here's what we decided to do. We decided that we're going to go ahead and use heuristics. We're going to use a model. We're going to basically oversimplify aspects of how the brain is organized, and we're going to try to measure things that we know have meaningful influence on development. And we're going to look at a variety of functional aspects of the person so that we can make a basically retrofit function to create a map, a model of how that person's brain appears to be organized and functioning. And we started with this primary heuristic, and we've been using this for a long time to teach. And let me just show you a couple things. Obviously, most of you know that this is a gross simplification. The brain is not an upside down beige triangle. It's a lot more complex than that. But this image, this heuristic, is capturing something that is true. The brain is organized in a hierarchical fashion. That's roughly accurate. It's also roughly accurate that there are parts of the brain, there are areas of the brain that have neural networks that are mediating or at least modulating certain functions. And when you go from the lower parts of the brain up to the higher parts of the brain, these functions are increasingly complex. So the brainstem mediates relatively regulatory, I don't want to call them simple, but they're simpler functions than the functions that are mediated by cortical networks. And again, those of you who are neuroscientists, I know you're ready to gag when you hear me talk like this, but believe me, I understand that function doesn't come from a region. It comes from widely distributed neural networks. But the final common or the necessary mediating components of a function related to speech and language are cortically localized. Now, the interesting and important thing here, and I'll talk about it a little bit maybe, but the most uniquely human aspects of our body, our whole body, are mediated through cortical functions. If you look at unique human DNA, the most the highest concentration of uniquely human DNA expressed is in the human cortex. And of course, if you look at the functions mediated by the human cortex, they are the most uniquely human functions. The capacity for reflection, for anticipating the future, for storing complex linear narrative memory and values and beliefs and speech and language. All of these things are to a certain degree uniquely human. Now, so we have this heuristic. Now, I could go on and on about other aspects of using this heuristic, but basically what we decided to do was try to make some decisions about what are we going to put in our assessment process? What are we going to do if we want to understand the pathway that someone has taken to the present? We need to ask a little bit about genetics, a little bit about epigenetic phenomenon, a little bit about intrauterine phenomenon. We need to understand the presence of both positive and negative experiences at key times in their life. And we were, mostly because of the work that I've been doing, we were very interested in essentially the neuroarchaeology of experience. And we wanted to measure that. And part of what we were struggling with, and a part of what you all are probably very well aware of, is that we know that adversity and a whole variety of developmental insults can impact developmental outcomes. But we also know that connection and positive experiences can buffer that. And so part of what we wanted to do was come up with a system that would allow us to measure things that were meaningful and things that mattered, and not measure things that we couldn't, that were not going to help us out in the process. And the reason we wanted to be really, and we made a lot of mistakes about this actually, the reason we wanted to do that was that we realized that we had to create a standardized assessment process that would get the same developmental information, the same current functioning information from large numbers of individuals. And if we didn't develop an assessment process that was helpful to the clinician, they would never do it. And we knew that if we wanted this to truly be an evidence-generating process, at the same time that it was helpful to the clinician and to the client, we had to be very intentional about what we measured and what we didn't measure. So one of the things that was obvious up front was, we need to look at adversity. I'd been studying the impact of trauma and neglect on development, and I knew that these things influenced functioning. And so, many of you are familiar with the ACE studies. Of course, California has been a pioneer state for a variety of reasons in sort of pushing the ACE studies and ACE-based problem solving. That's an interesting side debate for those of you who are interested in that. This is from a study or from a paper published with the primary authors of the ACE study, and I was a co-author on this, and basically looking at the relationship between adversity and risk. And the outcomes were really any, mental health, social health, physical health issues, all kinds of things. As you all know, the more you have adversity, the more your risk for these bad outcomes increases. But I knew that that was only a tiny part of the story. And when we started to put together our assessment pre-existed the ACE study, we were looking at not only adversity, but we looked at the timing of adversity, and we looked at the presence of relational connectedness which a lot of people now are calling positive childhood experiences. But we look at this assessment model, looks at relational connection and relate or not. And what we find is that if you have connectedness, if you're connected to family, community, and culture, you can have up to 3 adversities before you begin to demonstrate risk for poor outcomes. In contrast, in the absence of any of those 10 ACEs, if you have relational poverty, you're at risk for 2 of these adverse outcomes. And in our hands, the greater predictor of outcomes was not adversity, it was connectedness. So part of what we wanted to measure and make sure we measured was the timing of experience and the presence of attenuating or buffering factors when there were adversities. And so to make a long story short, a very long story, and it's actually, this isn't so short. I appreciate your patience. We developed an assessment process that looked at these things. There's a web-based tool that allows a clinician to enter data about just very scant data about this. These will be expanding areas that we will ultimately, when we have good information, we can fill this out. But the primary metrics are looking at adversity, the nature, severity, pattern, and timing of those adversities, and then the counterbalancing relational health items. And then we look at current functioning. Now, this is where a lot of people, this has been the part of this that a lot of people have found interesting. And it's different. So what we've done is we've taken our basic, the primary heuristic of the upside down triangle brain, right? And we essentially selected a number of functional areas that inform us about how well organized or how well developed that part of the brain appears to be. So these are just the labels of items where there's a semi-structured interview component. And we use that information to basically help us create a reconstruction of how an individual's brain appears to be organized and functioning. And so if you think about it, if you do conventional IQ testing, that tells you a little bit about the cortex, and different aspects of how the cortex is organized. If you do a trauma symptom checklist for children, that tells you about certain functions that are spread in different parts of the brain. And so essentially, rather than creating written textual reports with a few graphics, we've decided to create pictures of the way an individual's brain is organized. And we have a set of, here's an age-typical brain. The rating scale uses a stoplight color process where anything that's red or pink is undeveloped or dysfunctional. Anything that's green is essentially approaching adult-like or adult-like in functioning. And so a healthy newborn has a cortex that's not abnormal, it's just undeveloped. And their brainstem is much more adult-like than their cortex. And we have a whole set of, if you will, typical maps. And then we compare those maps to individuals who are experiencing clinical issues. And let me just pull one of these up. Here's an example of a child, a 9-year-old child. And this was the organization of their brain. They were basically a feral child. And in the year prior to this, creating this metric, this child had been in clinical care with a trauma-informed clinic where he was getting TFCBT every week for 50 weeks. And they went religiously and he didn't get any better. And again, I'm not saying this in any way to be critical of TFCBT. It's a great intervention when the cortex is available to participate. But this child was feral. He had no numeracy, almost no literacy. He was impulsive, aggressive, and TFCBT was out of sequence. This map told us that the sequence of intervention should involve somatosensory things, pattern, repetitive somatosensory activities, therapeutic massage, OT guided work, for example. And when that was started, this was his map a year later. And then another year later, or more than a year later. By this time, this child's ready to start doing parallel play, relational like work. And at this point, the child's starting to do cognitive work. And so there's a sequence in the dominant therapeutic technique used that matches the developmental stage of the child. And when we do this, we have tremendous positive impact on individuals who have struggled. Now, I could go on and on about this, and maybe I can show you some of this other stuff when we have Q&A, but part of what's happened is we started developing this model and talking and teaching to people about what we were learning and the mistakes we made, we did not have any formalized teaching or certification process. In part because I'm not an implementation scientist. That's not my primary interest. But when we started to get feedback that people who were hearing about our work were doing really weird, distorted stuff, we realized that we had to basically come up with an appropriate process where people were introduced to the content in a systematic and supervised fashion, and that if they were going to use these metrics, they needed to be trained how to use them. And so this process, even though it's relatively young, has had tremendous rollout. I mean, we've got, people using this model all over the world. It's the primary practice model in the child welfare and mental health systems in a couple of different communities, some countywide, some statewide. We've developed over time a version of this that is specific for the educational environment. So we teach the same concepts. So there's a parallel body of understanding and awareness across multiple systems. And we now have some communities where the juvenile justice, the child welfare, the early childhood, mental health systems have all had exposure to some of these concepts and are using the model in some fashion or other. And we've had a lot of uptake in Europe and in Australia. And the numbers of people, the number of reports that we have and has been skyrocketing. So in the beginning, when we were just doing this stuff, we would get, small amounts of data or information about experiences and outcomes. And one of the things that happened as more and more people learned how to use this is that our data set got bigger and bigger. So now we are at the point where we almost have 100,000, well, I think the last time I looked, we had almost 100,000 cases. What that allows us to do is, because there's an biannual fidelity exercise where everybody who uses this model is given the same clinical data, and then they all create a metric report. What that has allowed us to do is create a rating for inter-rater reliability and identify high fidelity users, acceptable fidelity users, and low fidelity users, and then tease out that data to begin to look at some really interesting questions. And so we've published on this. Now that we have a large enough data set, we've started to publish some of this data. And some of the things that we're finding are very interesting and I think very, very powerful. And let me give you one example. One of the dilemmas of understanding trauma is the timing of trauma. And anybody who's a clinician knows that if you have a traumatic experience at 2 months, it will have a different impact on you than if you have the exact same traumatic experience at 2 years or 12 years or 20 years. So when the adversity takes place makes a difference. And so we finally had a large enough data set to begin to look at a population of individuals who was a clinical population. They were in the child welfare or mental health system. It's not like they were healthy, but this sample had different patterns of adversity over the lifespan. So we had a large group of individuals who had not no risk, but low risk. Now, just to explain what risk is in our model, is it's determined by the balance between adversity and connectedness. So high adversity and low connectedness means high developmental risk. And again, this is no surprise to any of you who are clinicians. If you've got moderate adversity, but you've got moderate connectedness and relational health, your risk doesn't change that much in terms of expressing global health issues. And when we say global health issues, we're talking about mental health, social health, all the stuff that the ACE studies have been looking at. But if you have a high adversity and low connectedness, you've got high developmental risk, and then you are at high risk for significant problems. And again, the opposite is true. So developmental risk in this model is essentially, and I'll just show you, it's essentially the balance between this item and this item. So if you have high adversity and low relational connectedness, you have high developmental risk. So, and again, this is from the metric report. And let me go back and just show you this outcome. Now, so when we took a population that had low risk, not no risk, they functioned, if you look at their total global functioning of all of those brain related things that we measure, they were about 70% of a age typical population. And then if you looked at a individuals who had high risk all the way through from birth to age 13, they were about functioning about the 50th percentile. And anybody who's a clinician kind of knows the kinds of kids we're talking about here. So, but here's the interesting thing, and this is what this data pool is allowing us to start to do. We took a sample of kids who had high risk in the first 2 months of life, and then were taken out of that environment and put into a high, what we thought was a good environment, typically foster care or adoptive, or they were adopted. And their outcomes over the next 10 to 12, next 10 to 12 years were not so bad. Their outcomes were no better than kids that stayed in that environment. Now, this is not surprising to anybody who knows what it's like to go into foster care. And this, obviously, that's a whole different set of conversations. But here's the really positive part of this, a really important part that reinforces high quality home visitation and early intervention programs. If you take somebody who's in the low risk environment, and this is somebody where there's a little bit more stability, a little bit more predictability, that you take care of the young mother and the young infant. If you do that for 2 months, and then the wheels fall off and they end up in a high risk environment with lots of adversity over the next 10 to 12 years, their outcomes are essentially the same as if they'd never experienced that adversity. Now, I don't want to suggest that this adversity has no impact. It's just that the power of these first couple of months is related to the impact of experiences on these core regulatory networks that we have in our brain, norepinephrine, serotonin, dopamine, that are in lower parts of the brain, that are exquisitely sensitive to the nature of early life experiences, whereas an attentive, attuned, caregiving experience in the first couple of months basically helps build resilience for this system. And because this system plays a key role in subsequent organization and development of higher parts of the brain, that's an inoculating impact on the developmental process. Whereas the converse is if you have early developmental adversity that causes this system to be sensitized and dysregulated, you'll get a cascade of dysregulating input, even though you're no longer in the dysregulating environment. And so we feel very positive about, number one, the clinical outcomes that can occur with people who learn this model, who use this model. We don't think it's perfect. We've intentionally built it to become a self-correcting model. But when it's applied in residential, in early therapeutic pre-K, in outpatient mental health clinics, we see a lot of things like improvement in restraints. There's a significant reduction in the number of restraints and critical incidents, and that have a monetary impact. We see significant improvements in classroom experiences where the numbers of adversities, the number of referrals to principal just collapse, and the achievement between pre-NM and post-NM academic achievement is pretty significant. So we feel very optimistic that this approach has promise. There's a lot of room for improvement. There are a number of schools that have integrated this into their training in social work. Case Western School of Social Work, we're talking with Smith. We have Loyola in Chicago has been doing it for years. And we have a couple of residency programs that are teaching their residents how to use this model for clinical work. So I know that I've kind of pushed the time here a little bit. I'm going to go ahead and stop sharing for a minute and see if there are any questions or comments. I'd be happy to explain and expand on some of these topics if you guys would like to.
Thank you so much. That was such a thoughtful talk, especially talking about your experience as a trainee, kind of navigating the system of child psychiatry. A question is, how can child psychiatrists utilize the neurosequential model in their clinical practice, whether it's private practice or academics?
I didn't really, I kind of zoomed through one of those slides that showed the impact of introducing the neurosequential model on restraints and critical incidents. One of the things that we found, and the same thing has happened, and I hear this from other people who introduce other kind of relationally focused intervention models, is that just learning about some of the concepts without sort of the full certification results in about 30 to 35% of the observed improvement. So one of the things that people start to think about is de-emphasizing things that may not be that important, right? For example, if you have a social worker who has a client and they're supposed to fill out paperwork, and that's part of their responsibility to who they're accountable to, the real effective part of the work is to kind of put down your clipboard for a little while and just be present with the person and listen to what they're talking about. And so one of the things that we talk about in the neurosequential model is getting comfortable with being fully present when you're engaging with somebody to help them and understand them. And we teach people, again, and I alluded to it at the beginning of the talk, that the meaningful duration of time for the brain is on the order of seconds. It's not 45 minutes once a week. So if you are constrained by that structure because you work in a clinic and that's just the way you're taught to do it, remember that within that 45 minutes, if you have some moments where you are allowing yourself to be present and fully engaged, that will be powerful for that person, whether they're adult or a child. They feel that. and that can have enduring impact. And one of the things, again, this is sort of a neuroscience take on this, but when people are studying the creation of synaptic connections, what they find is, and again, synaptic connections is basically making a memory, right? Teaching something that there's a physical element to that.
Right.
So in order to make this synaptic connection actually stick and stay, you only need to have about 4 like appropriate levels of stimulation over the course of an hour, which is good, right? Which means that you can do therapeutic work. And if you have and anybody who does therapy knows what I'm talking, can think about, there was that time when we were right there and it was powerful, and then it was overwhelming, and they used some defensive thing to back out.
Right.
But then if they feel safe with you, if you let them do that, then they come back in again. And so a really good therapeutic hour has like 3, 4, maybe 5 of these little tiptoeing into intimacy moments. And I would just reassure people that that's where the magic happens, that you can do really quality work even within the constraints of the traditional medical model delivery of services. The other thing I think is really important as a clinician is that you are going to be very, very effective in engaging, supporting, and educating what we call the therapeutic web. So if you can help the teacher understand a little bit about this, if you can help the parent understand a little bit about this, if you can help, the coach understand a little bit about this child, then they can have many, many more of those moments during the week. And that will magnify what you're doing in the office.
Such an important point about dosing and about systems that children interface with. So it's not just once a week in terms of a touch point. It reminds me of something else you spoke about, and this is taking from the NAPA program, kind of the regulate, relate, and reason.
Yeah.
And frankly, we talk about this in our medical school a lot, when they're just, again, medical students are meeting patients for the first time. And I think that's such a valuable lesson, and especially when you're working with a child, the question of regulation.
Yeah. I didn't show the slide, but I'll just kind of walk through that. And, man, I need to fire myself again. I'm supposed to be talking about the neurosequential model. I just went to the neuro part. All right, sorry. So let's talk about the sequential part. And one of the things about the way our brain's organized is it organizes from the bottom up. And that's a sequential process. And I think everybody who's listening has probably heard a million talks about brain development and so forth, and knows that the cortex doesn't develop until later, knows about the adolescent reorganization and so forth. But what we don't talk about as much is the process of sequential sensory processing. So if you look at the way the brain's organized, every single sensory apparatus we have that's externally focused, our 5 senses, and all of our interoceptive feedback from where we are in space about, heart rate, oxygen levels, all of that stuff, it all goes into the lower parts of the brain first. And at that level, the brain can kind of make some determination. Do I need to take deeper breaths? Do I need to sit down? And if so, you will automatically, it will trigger certain behaviors. That's kind of happens out of our consciousness. But that information also starts to get sent up into higher parts of the brain for a second level of organization and interpretation. And because of the sequential processing, you don't really get to the smart part of the brain until you've gone through this reactive part of the brain and the emotional part of the brain, and then you get to the rational part of the brain. And it is a sequence that we need to respect when we are trying to engage somebody. If I want to communicate with words a concept, I have to go through the landmine of that person's regulatory state, and then their emotional cues and triggers, and then up to the cognitive part of their brain. But when you actually start to look at that, it's an obstacle course. It's very hard to accurately get cognitive content from one cortex to another cortex. It doesn't happen telepathically. It has to go through these other routes. And so what we've learned, and I think what everybody kind of figures out over time, is that when you're regulated, when these lower systems are quieter and you're not hungry, you're not thirsty, you're not cold, you feel safe, then that opens up the pathways to have more accurate interpretation of the upcoming information. And you appropriately give it emotional labels, and then you can appropriately put it in the right cognitive category. And people can reason with you. But if you get people emotional, then it'll get short-circuited in the middle. And if you get people scared, then they'll get short-circuited down here. And we do that all the time.
I'm thinking about certain settings also here at UCLA, like the emergency department settings, and oh, it's tricky.
Exactly. Yeah, it's very
Um,
tricky. But it's, again, it's one of the things that we do that that simple heuristic about regulate, relate, and reason, we teach it to everybody. We teach it to kids. And when you start remembering that in your interaction with somebody, you realize, all right, I need to take a deep breath, take a step back. Instead of yelling at you, I need to engage you. And I need to remember that human beings are relationally contagious. And if I'm all pissed off and agitated, I'm just going to make this kid more dysregulated, as opposed to calm down and hear what I say. So
100%. I apply it with my own children. That's another story and another
yes,
day, but it it applies.
yes,
We have time for about one more question. And I think, a lot of people are here and really just curious about next steps for the neurosequential model, and kind of in terms of also like advocacy. This is another kind of related
yeah.
question. What can we do as child mental health professionals?
Um, I think a lot of times we underestimate the influence we have on these systems. And the one thing that I would recommend for everybody who's a trainee is to continue, and actually everybody who's not a trainee, is that because our own lives are so busy and so filled with stuff, we tend to be satisfied with the inertia of the present.
Mhm.
And the prospect of leaving our comfort zone and going into the political arena, or going into the advocacy arena, or going into the arena where our medical colleagues that don't get the mental health stuff, it's daunting.
Mhm.
And many of us, when we've had the experience of leaving our comfort zone and challenging the dominant perspective, we get spanked. And
Mhm.
so, but I would not let that spanking discourage you. Just remember you have a lot of expertise. Remember that you have a lot to give. Remember that what you are giving will help improve their system, even though they don't understand that it will, or disagree that it will. And you just have to be persistent. But it's hard. I mean, it's systems change very slowly. All of you are in mental health, right? Think about how slow it is when you do therapeutic work.
Mm. Yes.
And then just realize that you've got a system of 50 people in a department who create this very powerful, if you will, pressure to do what we've always done. So interesting. I mean, then we use the evidence. See, if you're in a position of dominance, if you're the dominant perspective in a field, you can use evidence and evidence-based to reject novelty or innovation, yet you're not held to the standard in the way you practice. Because I've never had anybody show me anywhere that 1 hour a week, there's evidence that that's the dosing schedule that people should have for therapeutic change. But we do it, right? And
Right.
here's the thing I want you all to hear. We are letting the medical economic pressures drive our practice. We have to stop that. We have to literally stop that process, because it's leading to poor outcomes. and we need to push back. And so anyway, I'm rambling again. I'm sorry. I don't want to kick a
It's
beat.
wonderful, but thank you so much for coming today,
My
and
pleasure.
thank you all, and have great weeks.
Thanks, guys. Keep up
Yeah.
the good work.
Thank you so much. Bye-bye.
Bye.